Good morning, everyone. Wait a few more minutes. I see the participants climbing pretty quickly, so we'll wait for some folks to get in and we'll get started here in a few seconds. All right, let's get started. Good morning, everyone. My name is Stacey Lloyd, and I'm the Director of Digital Health and Operations at the AMA. Welcome to the Measuring the Value of Virtual Care webinar, part of the AMA's Telehealth Immersion Program. A few housekeeping items before we get started. You'll see our brief AMA disclaimer regarding the content for today. Next slide, please. Thanks, Bern. This session will be recorded, and then please feel free to use the Q&A to log any questions throughout, and we'll have some time to get to some of those later in the session today. So this webinar actually focuses on the AMA's recently released Return on Health research that explores how we can holistically measure the value of virtual care beyond just dollars and cents, and really proposing a framework for how digitally enabled care can drive value for varying types of practices, organizations across payment model, practice size, and use case. Our speakers will provide an overview of the research and have a discussion about how the framework can be used, opportunities for industry stakeholders, and more. So with that, I will briefly introduce our speakers who were both leaders on the project team and let them take it away. So first, Jacqueline Marks is a senior manager with Manatt Health, the healthcare legal and consulting group of Manatt, Phelps, and Phillips. She provides policy analysis, strategic business and project management support to a variety of healthcare stakeholders and has deep expertise in telehealth strategy development and policy analysis and digital health enabled health system transformation. Most recently, Jacqueline has helped advise 5 different state Medicaid programs in their telehealth policy responses to the COVID-19 pandemic, and has worked closely with one state Medicaid program to draft their temporary and post-COVID telehealth policies. And we also have Dr. Vimal Mishra. He serves as the Director of Digital Health here at the American Medical Association and is a medical director, associate professor of medicine at Virginia Commonwealth University. He provides clinical, strategic, research, and informatics leadership to the AMA Digital Health team and VCU health programs focused on developing, implementing, optimizing, innovating, and adopting EHR, telehealth augmented intelligence, clinical decision support tools, and other evidence-based digital health solutions. He is a practicing physician and has many publications, research funding, and invention disclosures in the digital health space. Dr. Mishra completed his internship and residency in internal medicine at VCU, and he's board certified in internal medicine and clinical informatics and holds a graduate degree from Duke School of Business. It's great to have you both here with us today. Really excited for this discussion. And Jacqueline, I'm going to let you take it away.
Great. Thank you, Stacey, and the whole AMA team. It's been such a pleasure to collaborate with you all on this really exciting work. So I'm going to provide a little bit of an introduction to the report, our collaboration with the AMA between Manatt and the AMA, and a little bit about the process, about how we developed the framework, and then I'll hand it over to Dr. Mishra. So the digital health team at Manatt has been intrigued by the question of how to measure the value of digital health for a while now. We have experience working with various hospital and health system clients who have been interested in adopting or scaling up their telehealth capabilities over the years, but often struggle to define the quote unquote return on investment for doing so. So through our work, we often assisted these clients in defining the ROI for a given telehealth or virtual care program in order to gain institutional and leadership buy-in to advance their virtual care programs. This experience led us to publish a white paper back in 2018 that proposed principles for calculating the return on investment, and specifically the financial benefits of a given digital health or telehealth program. Since then, we've continued to work with clients in this space and have witnessed the variety of benefits, both financial and non-financial, that can be realized through digital health. So in the middle of last year, in 2020, in the midst of the COVID-19 pandemic, when telehealth became such a critical care delivery tool across our healthcare ecosystem, we partnered with the AMA, who was also grappling with the question of how to measure the quote unquote return on health, not just investment, of virtual care. Our teams recognize that the full spectrum of benefits generated by virtual care is often misunderstood due to a lack of a comprehensive value framework. So together, our teams set out on a mission to propose a more comprehensive framework. So to that end, the recently released Return on Health report proposes just that, a new framework to better understand the comprehensive value of digitally enabled care models. The framework accounts for the various ways beyond just financial impact in which a digital health program may increase the overall quote unquote return on health by generating positive impacts for patients, clinicians, payers, and society going forward. So a little bit on the process that we took to develop this framework and the report. We started by developing an initial framework based on our collective prior work and our shared thinking among both the AMA and Manatt teams. We then tested and refined that framework through a series of interviews with approximately 15 healthcare stakeholders, including a diverse group of clinicians and thought leaders in the virtual care space. We then finalized our framework and drafted 4 case studies, which are based on real-world information collected from our interviewees, and 6 illustrative scenarios, which collectively aim to demonstrate how the framework can be used to measure the value of any given planned or existing digital health program. So a little bit about the objectives of the report, which are on the screen right now. So for our first objective was to define, again, the various ways in which virtual care programs can generate value with a focus on value for provider organizations, including physician practices. Second was to demonstrate how the framework is being used today and how it can be used in other practice environments to more precisely and holistically measure the value of virtual care through detailed case studies. And then finally, to highlight opportunities for healthcare stakeholders, such as payers and policymakers, to realize the full potential of digitally enabled care in the years ahead. Next slide, please. Finally, before I hand it off to Dr. Mishra to walk through the framework and some of our key findings in the report, we just want to take a moment to thank all of our research collaborators who helped to make this report possible. So with that, I will hand it over to Dr. Mishra.
Thank you, Jacqueline. Thank you, Stacy. This has been an incredible journey last year while we have been thinking about how can we really think about digitally enabled care and how does it create value. And as Jacqueline, you were talking about, I was thinking about it takes a village, and this has been a wonderful journey. So in terms of, so why is the framework important? I think we need to consider a few facts here. In COVID-19 pandemic led to dramatic increase in virtual care adoption, which was enabled by sweeping policy flexibilities like HIPAA or genetic site restriction and reimbursement parity. And there were many more which were implemented by federal and state legislators, regulators, and payers to enable social distancing. Many of these allowances are currently temporary. And as more than 30% of Americans are immunized and the pandemic is ebbing, clinicians are uncertain to whether they will be able to afford to continue their virtual care programs. On the other hand, multiple national surveys, physicians and patients shows high rates of satisfaction and desire to continue to leverage virtual care beyond the pandemic. And I will discuss some COVID-19 related surveys findings shortly. With digitally enabled care, and we define digitally enabled care characterized by seamlessly integrating in-person and virtually enabled care delivery models with fundamentally transformed value equation and has the real potential of breaking the iron triangle of cost, quality, and access. And we will be exploring this a little bit more as well as we move forward in the presentation. Another factor, Though the existing body of evidence regarding the value of virtual care has grown substantially in the recent years, it has narrowly focused on short-term measures of financial value. There remains a scant literature regarding long-term effects and other benefits of virtual care, such as improvement in access to care, clinical outcomes, the impact on the patient and clinician experience, and the potential of operational efficiencies and impact on health equity. With that, next slide, please. As I was talking about the surveys, and this is a COVID-19 healthcare coalition survey. This is a collaboration between AMA, MITRE, Mayo Clinic, DIME, ATA, Mass Challenge Health Tech, and Change Healthcare. During the COVID pandemic, we surveyed, the coalition surveyed both patients and providers to understand how telehealth is impacting their care and as well as the experience. This is the survey of 2007 patients who received at least one telehealth visit during the pandemic, who responded to the survey. As you can see, the survey response shows that telehealth has positively influenced important dimension of care for patients, including maintaining patient-physician relationship and preserving continuity of care, removing barrier to access to care, and visit quality has been reported really good, as well as the concern of privacy was low as well. And interestingly, many of these patients who responded to the survey also say that they saw the value of virtual care, and they would be actually willing to, about 40% patient would be willing to actually be okay with even a copay. So overall, the patients reported positive experience with telehealth visits and expect to continue to receive telehealth healthcare services beyond pandemic. Next slide, please. Here, this is our the COVID-19 physician experience survey with telehealth. Similarly, overall physician reported positive experience with telehealth visits and expect to continue to receive healthcare beyond, deliver healthcare services beyond pandemic. Here, what it had positive impact on all dimensions of healthcare, including clinical outcomes, patient experience, cost, and professional satisfaction. About 75% of the clinicians responded that the telehealth enabled them to provide quality care in the areas of COVID-19 related care, acute care, chronic care, disease management, hospital follow-up, care coordination, preventive care, and mental and behavioral health. And as you see on the right side of the screen, they want to continue to offer these services beyond pandemic. Next slide, please. These surveys also identified some of the barriers, and some of the barriers which would be very obvious would include challenges and concerns around low reimbursement post-COVID-19 pandemic. Also, there were concerns around technology challenges for the patient as a barrier to sustain use of telehealth, perceived barrier for patients including lack of technology and internet broadband and low digital literacy. And 58% of the physician respondents are not able to currently access the telehealth technology directly from the EMR. And these are some of the areas we need to think about as we move forward. Next slide, please. So what is digitally enabled care? Accelerated by the pandemic, we are entering an era of digitally enabled care, characterized by seamlessly integrating in-person and virtually enabled care delivery model that hybridize care delivery based on primarily on clinical appropriateness and other factors such as convenience and cost. And I'm going to be talking a little bit further about comparing and contrasting between different kinds of care which exist and how we think it is going to go forward. Next slide, please. In this figure, what you're seeing is how we are thinking about evolution from analog care, which is in-person only care, to digitally enabled care. Before COVID-19 pandemic, virtual care adoption was slow, representing less than 1% of overall healthcare volume. In most cases, the virtual care existed outside of the traditional healthcare delivery system and was often uncoordinated with in-person care. For example, if a patient would develop a rash or a fever over the weekend and would see a virtual urgent care provider who in most cases was not their primary care provider. That's the example of the parallel in-person care and virtual care. And for the most part, the virtual care ecosystem existed in parallel to and disconnected from the in-person healthcare ecosystem. How we envision moving forward that digitally enabled care models will be developed across the full range of disease acuity and across all clinical condition. The integration of new digital health solutions such as video visit, remote patient monitoring, asynchronous telehealth, continuous and passive sensors, and AI into digitally enabled care model offers the potential to address the quadruple aim in the new era of high access, high quality, lower cost, and high experience care. So how, if I have to describe, and the research team described this digitally enabled care as characterized by integrated in-person and virtual care based on clinical need and appropriateness with a high degree of coordination in between. Second, in terms of digitally enabled care, highly coordinated care experience across clinicians and settings enabled by interoperable telehealth and EHR platforms would be one of the other characteristics of digitally enabled care. Virtually integrated care teams can connect with each other and with the patient seamlessly and in the real time as needed. Another characteristic of digitally enabled care, which we envision. In terms of collection and use of clinical data, we envision data primarily will be collected virtually using at-home devices like remote patient monitoring, point of care, sensors, and labs, and automatically shared with the care team with some data collected in the clinic as needed. Data are used primarily virtually to inform diagnosis, and one of the other characteristics being continuously tweaking care plan moving forward. Next slide, please. Digitally enabled care would offer potential to become more accessible, higher quality, and lower cost. And I want to just kind of talk through a patient journey and how that patient journey is going to change from what we are today as in-person only care and what we envision would be in the digitally enabled care. So let's walk through for the patient with a hypertension. The patient is seen in person every 3 to 6 months and otherwise in person as needed. And with the medication management in the intermittent interval of time. In the parallel in-person and virtual care, the patient is seen in person every 3 to 6 months and otherwise in person or virtually as clinically appropriate. And still the management of blood pressure continues to be, and medication continues to be intermittent. Where in the digitally enabled care, we envision patient is seen in person less frequently, is monitored regularly for blood pressure, and has appropriately timed virtual coaching session to achieve or maintain blood pressure control through active medication management and lifestyle changes going continuously. Next slide, please. So as kind of we went through some of the idea around how analog care is going to develop into digitally enabled care. And as Jacqueline was talking about the thought process and based on the reviews of existing literature on the value of virtual care and interviews with more than 20 national experts, we are proposing a new framework for measuring the value of virtual care. The framework consists of 5 environmental variables and 6 value streams, as you can see here. The environmental variables defines the various contextual conditions that impact each value stream. The degree to which any of the streams generate value is dependent on these variables. So for example, type of practice, like independent practice, large group practice, healthcare systems, independent clinics, those environmental factors will impact resource availability, for example, potential of scalability, types of clinical programs, and clinical use case priorities. Another environmental variables like payment arrangement, such as fee for service, or if a clinic or a health system is providing care in pay for performance setting or alternative payment model setting, or capitation, that impacts financial sustainability of the virtual care and the business and strategic priorities. And the value generated by the value stream, which are vertical value streams, will change depending on what the environmental variables look like. Similarly, social determinants of health of patient population, factors like race, ethnicity, zip code, housing, income, and other inequities will also be measured, impacting access, benefit from the virtual care intervention we are doing with the patient, which will require intentional design, including device and platform selection, connectivity requirement, functionality, content, and user interfaces. Just example, the phone calls and how does the patient interact with that piece of technology. Clinical use cases. For example, primary care, specialty care, chronic care, acute care will impact the model design, data collection requirement, technology requirement, and business imperatives. And again, video visit, remote patient monitoring, e-visit, e-consult will impact the technology requirement and how patients interact with the system, the tools, and overall potential payment and operational requirements. So those environmental variables I just stated, and those various settings and context will impact each value stream and the degree to which any streams generate value. Going to the 6 value streams here, which are vertical lines here, defines various ways in which virtual care models can generate value. Each value stream is comprised of several substreams that provide several specificity regarding how value can be created and measured. For each of the value streams, there are specific metrics that, based on review of literature, are commonly used to measure the value of virtual care programs. So I'll give you some examples, and then we will go from here. I know this is just a construct of framework, and we will explain how this can be applied to real-world scenario in the next slide. So here, clinical outcomes, quality, and safety is often the most important goal among clinicians who implement virtual care. Is divided into 2 substreams. So for example, clinical quality and safety outcomes, such as can be applied here, like NCQA HEDIS measures can be utilized to measure the clinical outcomes and quality and safety. It could also be created, like, for example, ED utilization on readmission rate can also be utilized for measuring the clinical outcomes and quality and safety. Similarly, the substream of the clinical quality measures could be clinical processes, for example, medication adherence, adherence to evidence-based guidelines. Access to care is another stream here. Virtual care programs may reduce barriers that delay patients' access to timely care. This value stream seeks to measure the impact that virtual care programs may have on access to care by assessing programs' impact on availability, appropriateness, and affordability of care. And we have 2 substreams under this, which is availability of care. Example of measures could be third next available appointment, or percentage of patients who completed specialist referral within 14 days. Equitable care, for example, percentage of patients who delay care due to access barriers or out-of-pocket cost as a percentage of household budget could be utilized to measure access to care under this framework. Similarly, for family and caregiver experience, it could be measured using Net Promoter Score or patient activation measures. Clinical experience can be measured as ease of use for technology for provider, or work experience like engagement and satisfaction with work, or AMA Mini-Z score. Financial and operational impact. Healthcare organizations such as hospital and health system will be reluctant to adopt virtual care unless it is financially viable. This can be calculated, this can be measured using measuring direct revenue, example, payment for professional services, indirect revenues like new patient acquisition, patient retention, etc. And direct expense, for example, expense for setting up the telehealth program, operational efficiencies like reduction in length of stay, decrease in no-show rates, inpatient and ED throughput. And there are literature around how this can impact all these value streams. One of the most important conversation here is the health equity. Health equity is a cross-cutting component of this framework that seeks to understand the impact of virtual care programs across other value streams for historically marginalized patient population. There are 5 substreams which analyze the impact of inequities on clinical outcomes, which follows the 5 value streams here, which includes access, experience, financial, and operational impact as we move forward. One of the advantages of this framework is it's a flexible framework and acknowledges that different provider organizations will have different clinical and business rationales and value stream weight for pursuing different digitally enabled care models based on the environmental and strategic context. For example, a small rural care practice with large Medicare population paid for fee-for-service will experience the value of digitally enabled care very differently from a large vertically integrated regional health system. We suggest that the impact of digitally enabled care models should be measured on all these value streams, each of which can drive financial performance of an organization in a balanced scorecard approach to measuring and realizing the full potential of virtual care. So I talked a lot here, but it was important to kind of convey how this all thing interact and how different value stream has different kind of weight depending on the environmental variables and the context and the strategic thought process of that organization to think about digitally enabled care. Next slide, please. A slide back, please. So let's talk about the framework in action here. I'm going to talk about how about Virginia Commonwealth University. So VCU, and this is a real case study which has been published with the report. So VCU is a large healthcare academic health system that has a large service area covering urban, suburban, and rural geographies. Prior to COVID-19, VCU Health implemented telepsychiatry video visit in an effort to address psychiatry clinicians' shortage in rural area, but utilization was low. Since in-person interaction were unsafe during COVID-19, VCU expanded their telepsychiatry services to maintain access and continuity of care for patients. So the question here is, how do we implement the proposed framework, which we just talked about in length, to this use case of telepsychiatry at VCU? Next slide, please. So we came up with, after analyzing the data we got from VCU, we analyzed and put together the framework with measuring what were the environmental variables and what was the value stream, the care value stream, which was evident. Here, what we see, this is a type of practice, large academic medical center, payment arrangement type as a primary fee for service. Social determinant of health for patient population, which we analyzed, was age, because many of the patients who are older don't have the same digital literacy as younger patients, and we didn't want to have any inequities there. Clinical use case, of course, is telepsychiatry here, and the virtual care modality is virtual visits and telephone calls as well in there. And in the clinical outcomes and safety was not measured in this case. Access to care was seen to be at the level of pre-pandemic level, actually more. There were more patients seen virtually, and we will talk a little bit more about that. And there was a high patient, family, and caregiver experience, as well as better clinical experience and financial experience, which was shown here or was calculated, was no-show rate, which declined from 11% pre-pandemic to 6% during pandemic, which was really improvement in number of patients who were able to access care. And in terms of health equity, half of the telepsych patients under 30 years of age, there was no decline in ability to access telehealth among older patients. Next slide. The framework is broken down here in a little bit more details, which just explains each and every value stream in more details. What we are seeing here in this picture is the gray zone. The purple zone is in-person care, and the blue zone here shown is telehealth. And as you can see here, starting April 2020, more than 92% of the patients were seen virtually in April 2020, and it continues to be stabilized at around 80% of overall psychiatry visit, still there until February 2021. Again, showing that this virtual care for telepsychiatry is working well, it's well adopted. Physicians and the patients both like it, and they want to continue it. Next slide, please. Regarding patient, family, and caregiver experience, patients appreciated the option to receive telepsychiatry service in privacy and comfort of their homes. Actually, there are lots of anecdotal conversation talking about that they like getting care, telepsychiatry care at home better than in person. And in its satisfaction with inpatient services, and Dr. Bob Fendling, who is the chair for VCU School of Medicine, Department of Psychiatry, shared a very humanizing story with us, where he was talking about the patients who were admitted inpatients actually appreciated seeing their physician through telepsychiatry over the screen, rather than seeing their physicians taking care of them wearing full personal protective equipment, because they could not see the face of the provider. They could not see the connection. So I think that was another great thing around telepsychiatry during this pandemic, where the patient thought that the care was better and more humanizing. Similarly to the patient satisfaction with virtual inpatient care note above, the ability to connect via video with inpatient rather than the mask and facial shields valued by clinician and fostered more meaningful clinician connections. Actually, lots of psychiatry colleagues of mine here say that they would like to continue this kind of care where they can connect. They're more efficient and more effective that way. Next slide, please. I talked a little bit about the no-show rate, and it has for sure gone down. No-show rates among psychiatry declined from 11% pre-pandemic to 6%, and it continues to be a win for the VCU telepsychiatry. Here at the health equity, you can see here the purple bar, which is FY20, and blue bar, which is FY 2021. And what we are seeing here is the cohort in 8 groups on the x-axis and the percentage in the y-axis. what we are seeing here is that there was no decrease in access by older individuals as compared to younger individuals. And it was notable as older adults often have more difficulty accessing and using virtual care technology. So this is just an example of how we took that framework which was developed and implemented it into our real world example to see if it gives us the value or think about how we can continue to implement it. Next slide, please. We, as Jacqueline was talking about previously, we have 4 real world cases, one of them which we just talked about the Virginia Commonwealth University, and we are really grateful to Dr. Fielding and the VCU for sharing that use case and data around it. We have other illustrative cases which were based on research study and publications, and the 6 of them are remote patient monitoring program for diabetes management, tele-ICU, post-operative video visits, teledermatology, postpartum video visits, and primary care video visits. And I see this first conversation webinar today as just an introduction. There's a lot more to dive into and talk about and think about as we move forward. With that, I will give the mic back to Stacy.
Actually, we're going to give it to Jacqueline. She's going to do a little bit of the Q&A.
Great. Thanks, team. So, so the first question, Dr. Mishra, is, what are some of the challenges that our team ran into, would you say, when we were conducting this research and developing the framework? And how do you think those might be addressed in the future?
So, Jacqueline, I think the Manatt team and EMA team, we had very interesting conversation throughout the last year, and the major challenges we thought were the number of literature, the research was lacking in terms of lack of conclusive evidence regarding clinical impact, the financial impact, and other impacts like burnout and the virtual care capabilities. So there were lots of missing information and lack of research, I think, which should be the future thinking about it. And just to example, I think one of the things which came to us was the phone visit. And there was not too much literature around if the different modality of care, such as audio only visit, has what kind of outcomes in terms of clinical outcomes, impact, experience, access, how is it affecting those? So these all things were very evident during the research when we were thinking about it. And again, there were limited existing metrics around how to measure the value. So I think those were what comes to my mind at the top. Jacqueline, anything else you want to add there?
Yeah, I would say just looking forward, I think, as you mentioned, the evidence base is really limited because telehealth has only been around for so many years, and I think the pandemic really highlighted the various modalities that we might use, particularly as you mentioned, audio only. So there's very limited evidence specifically about that. But I would say, looking ahead, we would certainly encourage further clinical and health services research to help establish and grow that body of evidence. And then in terms of metrics, I think quality measure developers and stewards should consider updating and, where possible, streamlining metrics to better measure the value of virtual care and inherently recognize that massive shift towards this new mode of care delivery. Okay. So the next question is actually about the health equity part of our framework. Can you describe a little bit more how the framework assesses differences in outcomes based on characteristics such as race and ethnicity?
That's a very timely question, Jacqueline, and I think this framework does try to include and does the health equities continues to be the cross-cutting component of this framework that seeks to understand the impact of virtual care across the streams. So thinking about, how does the clinical outcomes and quality and safety of the care changes with different aspects or inequities present based on the income level, the housing level, the gender, and how does that impact the clinical outcomes and the access to care for those kind of patients with those kind of inequities or marginalized population. Similarly, is that subpopulation we are talking about, is the experience different for digitally enabled care versus in-person care, or is that different from the general population? Similarly, it also applies to clinician experience. Do the providers who belong to historically marginalized patient population, do they have different experience with digital health? What's the difference between taking care of a patient with a particular ethnicity? Does it change their financial and operational impact for the health system? So I think the health equity continues to be the cornerstone and really cross-cutting component, which I see as a filter to further kind of dive into and think about to understand all the value stream we just talked about, and how does the environmental factor impact that as well.
Yeah. And I would just emphasize, the case that we just spoke about with VCU. In that case, we were comparing a specific characteristic, demographic characteristic, in which case that was age, right? And so we were looking to compare the same metric across the different age groups. And in this case, the metric was really about access to care. And so thinking back on that graphic you just showed, we were very interested and sort of happy to see that the access didn't go down for the older population, as you might expect it might, when they had to transition to telehealth. So that was a situation where we were comparing that same metric across different age groups. And we saw that there actually wasn't an inequity in access across age groups. So that's a good example sort of how we compare different populations and subpopulations with using the same metrics to measure outcomes, or differences in outcomes, I should say. Okay, so another question, this is about the evolution model that you spoke about in the beginning. What would you say are some of the primary challenges that may be slowing down our healthcare ecosystem's evolution towards that more digitally enabled care model?
I think I did talk a little. That's something which I tried to convey during our conversation around what are the challenges and the barriers. And I think something which really jumps to the top is this uncertainty in terms of, will the payment parity continue? Will the reimbursement, will it be stopped? Will there new regulations coming in terms of what would be the originating site requirement be re-implemented? So I think those are the basic the questions people have. And I think from the perspective of AMA, we do support long-term fair and equitable payment to support sustainability for proven virtual care services for fee-for-service environment, as well as for value-based care moving forward. So I think, I think that's one of the major things. I think training, we talked about research as well. There's not a lot of evidence. So thinking about how can we generate more evidence around it, and also, create grants to really test out which models is the best and what conditions. So I think there's lots of opportunities there.
Yeah, agreed. So next question, what can payers and policymakers do to help clinicians overcome issues related to the unpredictable nature, as you were just mentioning, of the virtual care coverage and payment environment? I know it's a major barrier.
So I just kind of talked about a little bit, touched about it. I think just having we know, so Jenny's out of the bottle, the way I put it this way is, virtual care, we just saw VCU case here. We saw less than 1% before COVID. The same technology was implemented post-COVID with changes in regulations, changes in how it is paid for and how it is thought about with the training of the providers. Right now, the switch has flipped from 1% to presently 80% continued virtual. So that becomes a preferred model for telepsychiatry going forward. And that is so well accepted by the patients and the providers as well. So I think the question is, what was the barrier? I think the barrier was there were lots of restriction where and when telehealth can be reimbursed. And when that changed, people started realizing, and patients, providers, everybody started realizing that this is a very viable, feasible, and high quality intervention or delivery model. And so how can we continue supporting this in fee-for-service environment? And how can we continue to measure it, what we are continue to evaluate, so that there should be some kind of a quality metrics, which is not seen as a different than overall care delivery. Like, for example, hemoglobin A1C, right? You deliver care in person or virtually, that should not be changing overall. So there could be some tweak here and there, but at the same time, the question is, how are we evaluating the virtual care models moving forward? How are we continuing to pay for those models and support in fee-for-service as well as in the value-based care?
Yeah, that's a great point. And I would just, to add on to that, you mentioned that a number of these policy flexibilities are temporary and will likely sunset after the end of the pandemic. And I think 2 points that we tried to raise in the report, and I would just flag here as well, is I think that at least within Medicare, policymakers, thinking about, again, overcoming the unpredictable nature of coverage and reimbursement, policymakers should seek input and analysis from physicians and other healthcare professionals regarding their experience with the temporary virtual care service flexibilities, and then use that input as a basis for any decisions about which services might be continued to be delivered in a virtual manner when clinically appropriate after the end of the pandemic. And then thinking at the state level, policymakers, we might recommend continuing to support coverage of services provided via telehealth on the same basis as comparable services are provided in person. Okay, the next question is, how can government programs such as Medicaid and Medicare use the virtual care framework to implement virtual care into their policies?
So I think, Jacqueline, you kind of touched on this conversation a little bit. So
right.
As we are continue to move from a fee-for-service to value-based care, how do we support this transition as we are moving from there? How do we continue to pay for fee-for-service, as most of the health systems and the practices are not value-based care? But at the same time, having that framework and continued payment will honestly change, or it will help the practices to move from more value-based care, provide better care rather than fee-for-service, where it's like every encounter is paid for. And also this the new framework approach we just talked about, which is really thinking about how the analog care, which is totally in person, can be changed into digitally enabled care, which is not only virtual care, but really integrated care, where the patients, depending on the appropriateness of the patient's condition, appropriateness of the patient's need, and their choice, can be cared for wherever they are, with the right time, the right setting, and with the right clinicians. Yeah,
I think in addition to that shift from analog to digitally enabled care, I would also just add, considering the shift from just the financial ROI to the actual population level benefits, which is really the crux of the whole framework. So would just encourage a government program such as Medicaid and Medicare to consider those population level benefits, such as better access to care, improved patient experience, or more efficient operations. So those benefits that go beyond financial impact. And then finally, clinicians often face challenges practicing virtual care across state lines, which inherently impacts the value equation. So what steps can states or policymakers take to better enable clinicians to practice virtually across state lines?
Yeah, one thought comes here, Jacqueline, to my mind, especially around this Interstate Medical License Compact. And I think states should continue to think about joining this compact as the patients are moving across. With the COVID, I had several instances where the patient was in Florida and the patient's home is in Virginia, but cannot come here, but cannot get the care which they would have ideally gotten if they were in Virginia. Again, it was kind of a interesting evolution when we were thinking about these all conversation. Lots of patients for our health system at VCU come from North Carolina or come from Maryland, and it becomes really difficult to provide care for them virtually. They have to come in person if they have, in analog care world, but they can get similar care in their own state. So I think I will highly encourage for us, all the states and the Medicares and Medicaid to think about joining the states to join the medical licensure compact.
Yeah. Fully support that solution, or any other solutions that might better enable physicians to practice across state lines safely and appropriately, and in accordance with state oversight of physician licensure and telehealth. So I think I'm going to invite Stacy to rejoin us, and I think we might field a few more questions.
Thanks, Jacqueline and Dr. Mishra. Great presentation and discussion. We do have a couple of questions. And first, I just wanted to acknowledge that I was responding to all attendees in the chat to a couple of questions that came directly to panelists. So just wanted to share out some context behind some of those answers. So we had someone ask about being able to have a table that connects each of the streams and the value streams and the substreams in the framework with the metrics that we're speaking about, specifically in the VCU case study. All of the case studies will have those value streams and specific metrics aligned with those value streams within the Return on Health report. That can be found at www.returnonhealth.org, and you can download the full report as well as each individual case study. 4 of the case studies, I think, as Dr. Mishra had mentioned, are real-world case studies that we worked closely with the organizations to develop. And those metrics that are within the different value streams for those are actually metrics that they are tracking today. There are also 6 illustrative case studies that have example metrics that we had developed, following our literature review and interviews with the various interviewees that we talked with across the industry. So you'll get some examples in the alignment with each of those measures and how they kind of align with those different value streams within the report. And I think, Dr. Mishra, thank you. Could have done that myself, huh? But just wanted to explain the long answer verbally as well. And then additionally, we had a question come through the chat about any data on return on health for traditional model that we can benchmark with return on health for telehealth. And I, when I think about, and I'm happy for Dr. Mishra and Jacqueline to weigh in here, but this is something that I've thought about definitely as well with the concept of return on health. And it doesn't always or just have to apply to virtual care models, right? We can look at a lot of these value streams and really track to the traditional model, but I think we're going to see the most impact across these value streams when we get to that digitally enabled care model, which is the, hybrid of in-person and virtual care. But I don't know, Dr. Mishra or Jacqueline, if you have anything to add there about how we can approach this from a traditional model as well.
Jacqueline, you want to go?
Sure. So yeah, I think one of the things that we kind of came back to a lot of times when we were developing this research was that, like, we kept trying to separate traditional and virtual or digitally enabled care, and the key word that Stacey just said is hybridized care. So I think that we really are trying to think of it as traditional care or analog care was sort of the care of the past, and the care of the future is not solely digital. It is a hybridization of those two. So would just encourage folks to sort of think about it in that way. It's really using digital tools and methods of care delivery when it makes most sense clinically and it's efficient and it's safe, but always using in-person care when that's the most safe and appropriate care delivery measure as well. So I think, applying the virtual care framework to the analog care of the past, it is one way of looking at it. And then going forward is like, how can we continue to even increase the value delivered through these different ways of delivering care that are hopefully more convenient for patients.
Great, thanks, Jacqueline. Lita had a question that came through about situations where the Interstate Medical Licensure Compact does not make financial sense for physicians whose patients may travel, work, or live in different states. I think this is a great question. I think we've learned a lot over the last year about the impact that licensure can have on telehealth, and there's likely some opportunity for some of that to evolve. So I think there's more to come there. I think the industry is just really learning some of the limitations around that, and we'll probably be evaluating some potential next steps in addition to the AMA itself in terms of our policy as well. So more to come there. A couple of questions. Oh, did you have something to say, Dr. Mishra or Jacqueline?
Oh, no, Stacey, I think just want to also kind of reemphasize that when we were thinking about return on health, we were thinking about, yes, finance or financial outcomes are one measures, but really it should be thought about whatever, in healthcare it is, it's all about all 5 value streams rather than just financial. And so how do we think about it as we construct new care models in the future?
Great point. We also had a question in the chat from an attendee around kind of emergency protocols. Specifically, an example was given about a patient that called and was suicidal. I don't know if we have a great answer for that. I don't think we're going to give a specific direction on protocols or emergency protocols. What I will say is I think a lot of telehealth programs and telehealth in practice was implemented very quickly over the last year, given the COVID pandemic. And there's definitely a real opportunity to take a few steps back and start to really think about what those workflows are, what those protocols are that are going to allow for sustainable telehealth encounters and programs that make sense. I don't know, Dr. Mishra, if you have anything else to add, but I just want to make a plug for actually our next session or event within the telehealth immersion program, which is specifically an interactive session focused on behavioral mental health for telehealth. So I think if you join us again and want to ask that question a second time, I think you will be able to engage with and hear from some folks that may have encountered very similar situations in their own practices. But Dr. Mishra, knowing that VCUs was a psych example, I don't know if you have anything else additional to layer in there.
Stacey, as you said, I think I would love to talk about nuts and bolts. There is so much. It's such a high level conversation today. And there are so much in deeper understanding of how it operationally works. So I think that's a fantastic question. And we have had similar kind of conversation internally here as well. So I would just say that, Stacey, as you're talking about this, we implemented this quickly, but also thinking about in the future. You also kind of mentioned, and I think in the presentation we talked about that one of the things we don't know about is when is telehealth or virtual health appropriate to be used? There are lots and lots of instances. I don't think all care can be delivered digitally or on virtual, on telehealth. So I think that's research by itself in terms of when, how, and what to do when certain condition arises. So I think that's something we should surely think about and do a little bit more research around.
Great. Thanks, Dr. Mishra. All right, I know there are more questions, but we are getting very low on time. Bernadette, if you could go to the next slide. We do have an upcoming virtual panel discussion focused on this topic exactly, allowing for this conversation to continue. So while we didn't get to all of the questions today, we definitely encourage you to join us on the AMA Physician Innovation Network anytime between June 1st and June 11th, where you will be able to ask questions, maybe some that weren't answered today, maybe some new ones that come up between now and then. And you'll be able to access Dr. Mishra, other members of the project team, as well as many of our collaborators that helped contribute to this content, case studies, and the like. So really encourage you to go there. Always feel free to reach out to me or Bernadette directly as well, and we can circle back with questions that we missed on this as well. But really would love for you to join us there. And then one final plug, just because we're a week out or a week and a half out from the grant opportunity that was introduced for state medical associations and societies on our first webinar back earlier this month. If you are interested in continuing to attend these program sessions and also potentially even do some measuring of the value of virtual care in your own practice or at the state level, we encourage you to apply for some grant funding through the Physicians Foundation. Some of the details here, link to where to go. And if you have any questions, you can reach out to Danielle, the Physicians Foundation Program Officer, or myself or Bernadette, and we can also make that connection for you too. So I think that is a wrap. Thank you, Dr. Mishra. Thank you, Jacqueline, again for the discussion and the presentation today. We look forward to seeing you at our future Telehealth Immersion Program events. And again, feel free with questions to reach out to myself or Bernadette, and we can help to answer them. Thanks again.
Thank you so much.
Bye, everyone.